Can you see my screen?
Yes, doctor.
Okay. Close this. Okay. So today we're going to talk about indices. We're going to talk about orthodontic indices. So what's the content today? We're going to go through the introductions. Then we're going to focus a bit more on the in-text or orthodontic needs, which is IOTN, which you're going to use it most frequently in Malaysia. Then we're going to talk a little bit about in-text complexity, outcome, and needs, ICON. Then peer assessment rating in-text, pass score, summary occlusive in-text, and then we come to the final conclusion. So what's the outcome today? So at the end of the lecture, you should be able to list and explain the property of the idea index. So the index, there's certain criteria. Then discuss the detailed property or application IOTN. So IOTN, you're going to use it almost in a daily basis in the government practice, but in private, maybe not that much in Texas. So describe the component of ICON, then describe the summary occlusive in-text, and you should be able to describe the component and application of pass in-text. So ICON, SUMO, and pass score, then maybe just know it briefly. But IOTN, I want you to know it inside out. We're going to use it in the clinic. So the instructions. So what is in-text? So what we're going to use it for? Then what's the purpose of having the in-text? So in-text is an instrument that enables the quantity of the disease to be measured. So in-text is not only applied to ortho, they apply to all the medical sciences. So they allow the comparisons between the different study and different data set when the same in-text is used. So using the same in-text for different populations, then we can compare the result. Then you can compare the data between the different populations. Then the disease trend may be identified. Then in the orthodontics context, index is a method that assigns a numeric score of numeric label in order to rate or categorize a person's occlusion. So let's say, for example, I give you a 4 IOTN 4 or 5. You know that patient is in the great need. Then we give IOTN 1, then patient is in the less need. So there's a numeric score. So property of the ID index. So what is the ID index? It should be simple, easy to understand, and easy to learn how to use. Everyone can use it. Simple. Keep it simple. The objective, not subject to the examiner opinion. So it must be objective. So your opinion and my opinion doesn't matter. As long as you use the same index, then you should be measure what we want to measure. So it should be ready to able to measure what is intended to measure. Let's say IOTN 5 means the severity of the occlusion is more than IOTN 1. So have a clear-cut category that make it easier for the examiners to make a decision as to which category a condition should be fit into. So it must be clear, like IOTN 1, 2, 3, 4, 5. Must be certain criteria to fit in that severity of the occlusions. Must be reliable, give the same result each time it's used the same conditions. So let's say use it today, tomorrow, or next year. You should be able to get the same result. Then reproducible, minimum or no variations in measurement made on the same condition at a different time. Diagnostic criteria clearly defines the same, reliable, reproducible. Sensitive, should be able to detect small changes. This one, not many index can do that. So the index can be a bit more sensitive. Certain index are not that sensitive. Acceptable, not painful, embarrassing, or take a long time for the assessment. So the index will be simple. If it takes too long to assess or make the decision, then maybe it's not a good index. So what's the common indices used in dentistry? For example, we use the MFT for the caries, for decidus, adult, then periodontal disease, we have CPI, then fluorosis, enamel defects, we have Dean's index. So there's a common index and indices in the dentistry. But what about orthodontic index? So indices are used extensively in the Northern Europe in determining access to the public health orthodontic or the level of third-party payment. So this one, because we have the limitations, there are quite a small number of orthodontists in Europe or Asians. So they have to come up with the index to filter all the patients who need the treatment. So not all the patients will get the treatment free or subsidized from the government. So we have to exclude certain patients via too mild, then they are not qualified for the government treatment. So the patients have to go through this orthodontics index or the classification or categorize in different categories, then we can allocate the budget a bit better. So have a role in the resources allocation. Like say we have to allocate the resources and the money to a certain group of patients, which need the patient more than the others. So planning and promoting treatment standard that identify the prospective patients. So for example, IOTN 1, then in the less treatment need, then maybe we'll exclude to a patient in the government service because there are limitation of resources, the orthodontists, and the facility. So we have to target the more severe group in order to get the treatment. So informed consent. So this one, sometimes you have to inform the patients, they have IOTM 5 before they start treatment. So this is again used for the informed consent. The assessment of the outcome of treatment, then this is usually a PASS score. Then quality assurance and research. Sometimes research we have to compare like Malaysia and UK. Then we use the same index. Then we can compare the populations, our quotients and severity. So what's the type of indices used in orthodontics? So there are 5 types of index, each of the distinct purpose. And indeed is a purpose rather than the content of conventions of the index that distinguish it. So it's a purpose. So what's the purpose? You want to, for example, malocclusion or complexity of treatment, then use a different purpose. Then result, you use a different purpose. So for diagnostic and classifications, then we use the anchor and the insights classifications, which is a British Standard Institute, ASI. So diagnostic classifications and most common is anchor classification, where it's a subclass used to describe the incisor and buccal segment relationship separately around the ease of communication between orthodontists. So for example, let's say I call you up in the office. Today I tell you I'm going to refer you a class 2 division 1 malocclusion. So instantly you can picture you're going to have a patient coming in with an increased overjet or high upper incisor, there may be a little deep bite or maybe a gap between the teeth. So there's a communication between the dentist or the orthodontist. Epidemiology indices. So these indices record every trait in a malocclusion to allow estimation of prevalence of the malocclusion in given occlusion. So these are usually for research purpose. For example, BR, perhaps sorrow, somewhat conclusive index. So these are always for description of a population. So let's say I say Malaysia, we are more class 3 than class 2. Then you can picture we all have a longer lower jaw. So this one for epidemiology indices. So treatment needs indices. So allow categorization of malocclusion according to the level of treatment needs. These indices yield the score of each trait or component that is weighted to calculate the overall score. So this one, every malocclusion features, they get certain score, then they add up, then it becomes a sum of the amount, and that reflects the severity of the malocclusion. So we have so many Draco, Salmons, IOTN. So we're going to talk about it one by one. So treatment outcome indices, this one usually is a PAR score or PAR index, has been developed specifically for this purpose. So you want to evaluate the patient before and after treatment, then we want to compare whether the result is good or the treatment is well done. When you use this PAR or the SUMMA index to assess the occlusion or the treatment outcome. Then finally, we have this treatment complexity index. So this one index of complexity, the outcome and the need. So this one, they assess the complexity of the treatment. So we can allocate the treatments to the general practitioners or sometimes the specialists or the consultants according to the complexity. So indices used in prevalence of malocclusion, we have so many. We have IOTN, ICON, PAR, and SUMMA index. So we're going to talk about these 4 today. So the first one is IOTN. So IOTN is developed as a result of the government initiative. Because like I say, the governments, there are too many patients, but we have limited resources, orthodontics facility or money. So we have to target to the most severe group rather than those just a malocclusion, very mild. So they determine the likely impact of the malocclusion on individual health and psychology well-being. So there are two components. So we're going to focus on IOTN today. So this is the main topic today. So just pay attention to it because you can use it in the clinic. So we have two components. One is the dental health component. The other one is aesthetic component. So two components, not dental and aesthetic. So the dental health component is based on the index used by the dental board in Sweden, and it designed to reflect on the occlusal trait, influencing the function and longevity of the dentitions. So it derived from the alignments and occlusions dental cancer. So single worst features of the malocclusion is not this. So for this IOTN, we only pick one feature. Let's say you have a crossbite, then increased overjet, impacted canine. So we're going to pick one of these features. We're going to mark it down. They are not cumulative, not like others in text. So you can add up the score, and it give you the severity of the malocclusion. But this IOTN only based on one worst feature, so one single worst features. So there are 5 grades. Grade 1, 2, 3, 4, 5. They are according to severity. And grade 1 is no need. Then grade 2, little need. Then grade 3, moderate. Then grade 4, grade 5 is great and very great need. So let's say I give you a category 1 and 2. Then you are not qualified for the Malaysia government orthodontic treatment. So when I give you 3, 4, 5, then you're qualified for the Malaysia government's orthodontic treatment. That's how we filter all the patients. So according to this chart, let's say the grade 5 is very great need, then grade 4 great, then grade 3 moderate, then grade 1 and grade 1. Grade 1 and grade 2 is little or none. So this Manchester University, they come up with this IOTN ruler, so to help you to make the assessment faster. So look at this ruler, it's specifically designed for IOTN. But without this ruler, you still can do the IOTN assessment or scoring. So this IOTN ruler is just to make your job a bit easier, but without this ruler, you still can do it. Look at this ruler. Look at this ruler. So you see the design of the ruler is very simple. On the left side, it measures the overjet. So let's say the overjet, then it's less than 3, then maybe give IOTN 2, then maybe 3 to 6 IOTN, then get the 3I in competent lips, then 2C is competent lips, then 4 and 5, then maybe 6 to 9, then after 9, then it give you 5 IOTN. So these are all summary. Then for 5, then give you a summary. For 5, then there's like cleft lip and palate, it give you 5. Then hypotension, it give you 4. So this one is summary of the IOTN. Then this one is just a displacement. Displacement means crowding. Crowding, then this one is measured contact point or open bite. So let's say this open bite, then 4 on the right side, then give you 1, then 2, 3, then more than. This one is considered 4. Then, but this IOTN, when we grade the IOTN, then we go according to the motto. Remember this motto. So first one is missing teeth. Missing teeth always come first. Let's say I have a missing teeth problem, overjet problem, then which one you're going to choose? You're going to choose the missing teeth rather than the overjet. Let's say if overjet, then you have an overbite problem. So which one you can choose? You're going to choose the overjet. So according to this motto sequence. So motto stands for first one, M missing teeth, then overjet, crossbite, displacement, which is a contact point or crowding. Then finally we come to overbite. So according to this priority, missing teeth, overjet, crossbite, displacement. The last one is overbite. So again, this is IOTN ruler. So it just summarizes what I said just now. So you see on the left side, they measure the overjet, 3.5, 6, 9, 17. Certain people are 17 now. So usually more than 9 is considered severe. They give you 5A, 5A. And this one is reverse overjet, then give you 3 and 4. Depends whether the patient have the mastications or the speech problem. And this one on the right side gives you displacement or open bite. So there's abbreviations, I for incompetent lips, then competent lips, then overbite, gingival and palate trauma, then deviation, interdigitation. So it's just a short form, abbreviations. So this chart, it just summarizes all the IOTM problem. So let's say for the first one, we have this A, B, C, D, E, F, G. So this one is just categorize all the problem. So for A, then it means overjet. So if the overjet is more than 9 millimeters, then it gives you 5A, 5A. If the IOTN is 6 to 9, then it gives you 4A. And IOTN 3 to 6 with incompetent lips, then it gives you 3A. And if the if the overjet is 3.5 to 6 millimeter with competent lips, then it gives you IOTN 2A. Then same reverse overjet, then is less than 1 millimeter, give you 2B. If between 1 to 3.5 millimeter reverse overjet, give you 3B. Then more than 3.5 millimeter, they give you 4B. But pay attention to this 3B and M. B and M is quite similar, except you see when the 1 to 3.5 millimeter, when I have these mastications or the speech problem, then they upgrade to 4. From 3, then upgrade to 4. But they give you a different number. So let's say the patient have a reverse overjet, 1 to 3.5 millimeter, then with the speech and mastications problem, then they upgrade to 4M. So let's say have a reverse overjet more than 3.5 millimeter with the speech and the eating problem, then they upgrade from 4B to 5M. 5M. So you have a problem with the speech and eating or mastications, then we upgrade to one more category. Then we have this overbite, and which is about 1 to 2, then 2E, then 2 to 4, then 3E, then more than 4, 4E. Same with the tooth displacement, which is a crowding. Crowding is the most common problem for orthodontic. So when it comes to crowding, they consider 1 to 2 consider mild, then 2 to 4 consider moderate, then it's more than 4 consider severe. So it's more than 4, then give you 4D. But more than 4, you still consider 4D. There's no more than 4, then, there's no category 5. Because crowding is not considered a severe problem. It's a very common problem for braces. So of course, we have others like cleft. So if you see the cleft patient, then straight away you go for 5P. 5P. 5P is the most severe one, 5P. So you see a cleft patient, you don't have to see the other features, then you grade the patient according to the category, which is 5P. 5P. So it partially erupted, then maybe it's a 4. So let's see. Something wrong here. So it impacted, then it gives you 5I. 5I is a crowding, impeded eruption. But if it partially erupted, then they are leaning on next to, which is considered impaction, but it's already visible in the mouth, and consider 4T. And supplemental, which is extra 2, is a 4X. So this number is according to the severity of the mouth occlusion. But this alphabet, they give you the category of the mouth occlusion. So A for overjet, B for reverse overjet, C for crossbite, D for displacement, E for open bite, F for overbite, then G is a pre and post normal occlusion. So I just want to explain this G. G usually for the 2G. 2G it means up to the half unit discrepancy. So it means you can have a class 2 half unit or class 3 half unit. It means they are not class 1, or they are not fully no interdigitations, no perfect interdigitations. Up to half unit discrepancy, we consider 2G. Then we have hypotential. The less severe one is 4H, means less than 1 tube. There's only 1 tube per quadrant, it's more than 1, 2, then you consider 5H. So that 2 teeth missing in one quadrant, then you consider 5H. And again, this one 5I, it may impacted totally, not visible, then usually it's impacted canine, and give you 5I. But pay attention to this impacted, you're not including the third molar. So we have impacted third molar, then you're not giving the 5I. Usually 5I is given to this impacted canine or impacted second premolar. This one 4L, 4L is lingual crossbite with no functional occlusion. So usually you have to involve the whole buccal segment using the lingual crossbite, and you get a 4L. Reverse overjet, like I said before, is from the B, reverse overjet, but we have the mastications and the speech problem, then upgrade to M. From 4, upgrade to 5, then 3, upgrade to 4. Then cleft patient, straight away to get 5P, and then submerge 2, you get 5S. 5 submerge 2 usually for decitus, submerge 2, 5S. Then these are partially impacted against the next two, 40, the supplemental, or X. We can look at this one by one with the clinical pictures. So dental health component, each of the 5 categories is subdivided and given a letter. So for example, overjet, more than 6 millimeter, but less than 9 millimeters, given a 4A, then more than 9 millimeter, given a 5A. Impacted 2, then it gives you the 5I. So when categorizing, choose only the most severe trait. So let's say you have 4A and 5I, 4A and 5I. Of course, you go for the 5I, because 5I is more severe compared to 4. 5 is more severe compared to 4. So you go for the 5. So the first one, grade 5, we have overjet more than 9 millimeters, then 5M overjet, reverse overjet more than 3.5, then with the speech and the eating difficulty, then the 5H extensive hypotonsia, which is more than 1/2 per quadrant, then 5P is a cleft lip and palate, then 5I is impeded eruptions or totally impactions, then 5S is submerged decitus. So the first one, overjet more than 9 millimeters, it's very simple. So you just bring a ruler and parallel to the occlusal surface. And this one, you just measure the overjet. It's from the labial surface of the upper incisor and to the labial surface of the lower incisor. That's how you measure the overjet. So make sure they're parallel to the occlusal plane. So that's how you measure the overjet. So if overjet more than 9 millimeters, then consider 5A. 5A. So this one also 5A, more than 9 millimeter overjet, 5A. So 5M is a reverse overjet, more than 3.5 millimeters with the speech and mastications or the eating problem. So same thing, you measure the overjet based on the labial surface of the lower incisor to the labial surface of the upper incisor and parallel to the occlusal plane. That's how we measure the overjet. So reverse overjet more than 3.5 with the speech and mastication problem, then consider 5M. Then 5H is extensive hypotonsia, which is more than 1/2 per quadrant. There's like a 2 teeth missing in one quadrant, maybe 4, 5, sometimes 2, 4, 2, 5, and maybe consider 5H. So for example, this patient have a missing lateral incisor on each quadrant. So you have one missing, maybe give it 4H. But let's say you got 2 missing, lateral incisor and the premolar also missing. Then consider 2 teeth or more than 1/2 per quadrant, then this is 5H. If 1/2, then maybe 4H. If more than 1, then consider 5H. Same, see this one missing, maybe 4 and 5, and this one consider here more than 5, 4 and 5, then this one consider 5H. Okay, then sometimes you can verify by the X-ray. See this one have missing, also many missing teeth. This one lateral incisor, then premolar also missing, then 2 teeth per quadrant, then consider 5H. Okay, so cleft lip and palate. So this one quite easy to identify. When you see the cleft lip and palate patients, then straight away give them the 5P without hesitation. You don't have to go for this impaction, crowding, open bite. Straight away give them 5P. The reason why is cleft lip and palate patient, they usually have all the problem. You name it, infections, open bite, crowding, missing teeth, sometimes extra teeth. They're all sort of problems. So we give them 5P straight away. So this one also 5P. You see a cleft patient, they give them 5P. So impeded eruption, which is an impaction, then usually for the canine or the lower second premolar. Why? Because they're the last one to come out in the mouth. So when the last one to come out, then usually not enough space. So for example, this one lower second premolar, this one impacted and cannot be visible in the mouth. This one considered 5I. And the impacted, you cannot see it, then consider 5I. So this one also same. You see the upper left canine. Upper left canine is impacted, cannot be seen in the mouth, totally impaction. Then this one consider 5I. So the first thing you see the patient in the mouth, then before you do anything, first thing, count the teeth, count the number. So you make sure everything is there. If not there, then you have to do some examinations and investigation further. So the last one is submerged decidus. So submerged decidus usually are considered submerged when the tooth is gone beyond the contact point. So let's say this one is already submerged beyond the contact point of the 6, then consider submerged. So this one submerged. So what is the reason? Usually submerged decidus is due to the ankylosis of the tooth. It means other teeth will continue to develop, they become longer, but this decidus will be left behind because it fused to surrounding structures. So this one consider ankylosis, consider submerged. So this one we give it 5S. So why I give you 5S? Because this submerged decidus consider urgent. You have to do something. If you do nothing, then mostly the permanent tooth will be impacted, and other teeth will tilted, and they go into the space of this submerged tooth. Then we have grade 4. Grade 4 is considered grade need. Then we have overjet, which is less than 9, but more than 6. Then reverse overjet is more than 3.5, without any speech or mastication difficulty. We have crossbite. So pay attention to this crossbite. It means the anterior posterior crossbite is more than 2 millimeter discrepancy between the ICP and the RCP. So ICP means the intercuspal, then RCP is retrograde cuspal position. It means it must have an initial contact, and before the displacement, forward, left side, right side, or backward. So it must be an initial contact with the displacement, which is about more than 2 millimeter, then consider 4C. So this one crossbite without any displacement, then it's called nothing. This crossbite must have a displacement, which means the discrepancy between the ICP and the RCP. 4D, like I said before, it just means crowding. So the severe displacements more than 4 millimeter. More than 4 millimeter, then consider severe displacement or severe crowding. Then give you 4D. Then 4E just means anterior open bite or lateral open bite, which is more than 4 millimeters. So open bite and displacement, they are quite similar. So both also 4 than 4 millimeter, then they score 4. Also for displacement, 4D, open bite, 4E. Then we have deep bite. Deep bite must be have a gingival or palatal trauma. So it must be deep until you can strip off your gum or have an indentation or potential traumatic bite. Then it gives you the 4F, which is a deep bite with a traumatic or indentations to the palate or the gingival. Then 4L is a lingual crossbite, posterior lingual crossbite, no occlusal contact on the buccal segment. Then 4H is a less extensive hypodontia, which means usually one single tooth per quadrant. So you have hypodontia, not that severe, just one tooth per quadrant, then consider 4H. Then 4M, same, is a 3B upgraded to 4M. So you remember the 3B is a reverse overjet 1 to 3.5, and without difficulty. But if with difficulty, investigations and speech, then we upgrade to 4N. Then we have 4X with supernumerary. So you have a visual dance, whatever supernumerary present, supplemental, then consider 4X. 4T is a partially erupted. It means they're erupted a little bit. You see the crown a little bit, but they're not coming through. they impacted. Then they tip against the next two, then consider 40. So we can look at it one by one. So reverse overjet 3.5. No difficulty, then consider 4B. Then with difficulty, consider 5N. So same for this, and it's 1 to 3.5. Then no difficulty, then consider 3B. With difficulty, consider 4N. So this one reverse overjet, then between 1 to 3.5. So between 3.5, and if there no difficulty, then consider 3B. With difficulty, consider 4N. So crossbite, anterior and posterior with 2 mm discrepancy. So it means this patient can bite edge, then before the jaw slide forward. So you see I have initial contact on the central incisor, then before the jaw slide forward. So there's a discrepancy between the RCP and the ICP. So it must be have this initial contact, then displace forward, or sometimes left side or right side, or sometimes backwards. So it must have initial contact, then this crossbite is valid for the IOTM. So severe displacement, this one very common for crowding. Braces usually deal with crowding, everyone have crowding. So if the severe crowding more than 4 mm between the contact point. Look at the contact point here, lateral incisor to canine. You measure this contact point. If the displacement is more than 4 mm, then consider 4D. So this one also, displacement between the contact point, lateral incisor and canine, more than 4 mm, consider 4D. Let's say this central incisor and lateral incisor, they're less than 4 mm. I guess for this, maybe just 2 to 4, between 2 to 4, they give it 3D. So if displacement very severe displacement, very crowded too, and usually they get 4D. Again, same this one, lateral incisor to canine. Look at it, severely crowded, or this one canine buccally displaced. So this one considers severe crowding. They give you 4D. Same on the right side, lateral incisor in canine. This one consider 4D. Anterior open bite, lateral open bite. You just measure from the furthest part, usually the occlusal surface, whether they are incisor, canine, or premolar. So you measure the occlusal surface or the occlusal surface. That's how you measure the open bite. So let's say the open bite, there's more than 4 mm, same with displacement or crowding. More than 4 mm, consider severe. So this one gives you 4E, whether they are anterior or posterior open bite, 4E. So deep bite must be deep enough until they touch the touch the palate or the gingival surface. So you see this one, consider deep bite. Then look at the palatal surface. So the normal bite usually is overlapping between the upper incisor and the lower incisor about 1/3 or 2 to 4 mm. The magic number, always say 2 to 4, then you are safe. So overlapping between the upper and lower incisor, 1/3 or 2 to 4 mm. Then if they're deep, it means they overlap more than that. So you look at the palate. So sometimes the palate will be injured or they have indentations, or the more severe ones, sometimes they strip off the palate or the gingiva. So these are considered traumatic bite or deep traumatic bite. So when this happens, then the patient will get 4F, deep bite with gingival or palate trauma. So if they are not having this strip off gum or the gingival palate trauma, then they consider less severe, then they give them 3F. But with this gingival palate trauma, then you consider 4F. So you have to look at this palate or the gingival that have trauma. Again, 4L is included crossbite, which is no contact on the buccal segment. So this one, you see the whole segment is in the scissor bite or lingual crossbite. So when you refer the crossbite, you refer to the lower segment. Let's say it's a lingual crossbite, then means the lower teeth is biting more lingually. Buccal crossbite, it means the lower teeth is biting more buccally. So lingual crossbite or scissor bite, you refer to the lower teeth, which is biting more inward compared to upper teeth. So like a scissor. So this one like a scissor. They give you 4L. Then 4x is supernumerary present. So whatever extra t, then or 2, then we consider 4x. For example, this one is a mesodense, then consider 4x. So whatever extra t in the mouth, then you classify as a 4x. So partially erupted, tip, again the adjacent tooth, this one consider 4t. So this one usually is the second premolar. So you see the second premolar, they're erupted, but they're impacted. Okay, now we come to grade 3. Grade 3, we have less severe, but still considered moderate. Then we have 3A, which is 3.5 or 3.6 to 6 millimeters with incompetent lips. So let's say competent lips, we give them 2A. Incompetent lips, we give them 3A. Both also with a 3.6 to 6 millimeter overjet. Then we have the 3B, reduced overjet, then 1 to 3.5. Then without any speech or mastication difficulty. If they need this difficulty, then we upgrade them to 4M. 3D displacement 2 to 4. 3E same, open bite 2 to 4. And 3F is deep bite, like just now, without any occlusal, without any gingival or palate trauma. So this one reverse overjet less severe. You can see this one less severe, maybe less than 3.5. Less than 3.5, then we give them 3B. This one anti-open bite between 2 to 4. Then this one deep bite without any gingival or palate trauma. So we come to grade 2, we just need a litany. So this category usually not qualify for orthodontic treatment in the government practice. So we have 2A, which is overjet, overjet 3 to 5, 3 to 6, then with competent lips. So if the lip competent, 3 to 6, then consider 2A. And 2B is a reverse overjet, less than 1 millimeters. Then 2D displacement, 1 to 2 millimeters. And 2E anti-open bite, 1 to 2 millimeters, and with this displacement. So displacement and the open bite, they always stick together, same measurements. And 2F, increase over bite, more than 3.5 millimeter without gingival contact. Then this one is pre-normal and post-normal occlusion with no other abnormality. So this one, it means patient everything perfect, just that the bite is not perfect. There are no full interdigitations. So I will show you some picture later. So include up to half unit discrepancy. So this is the reverse overjet. You see just tiny bit reverse overjet, which is less than 1 millimeters. Less than 1 millimeters. Usually HH. Then consider 2B. So let's say this one is a little bit more than 1/3 or more than 4 millimeters slightly, but they are not having this gingival contact. Then consider 2F. Sorry, 2F, yeah, 2F. Then let's say have open bite, not too severe, less than 2 millimeters, then consider 2E, anterior posterior. Okay. Oh, we have 2G. Okay. Yeah, maybe I'll show you in the clinic later if I have a chance. Okay, so we have one it means no need lah. So extremely minor malocclusion, displacement less than 1 millimeter. So it's just minor irregularity of the tooth. Just a little bit malocclusion, a little bit not straight the teeth, everything's look fine. So for example, look at this case. You see the teeth is all straight. There may be a little bit minor rotation here and there, and less than 1 millimeter between the contact point. So this are considered very, very minor needs. So this kind of patient, straight away we turn them down. They are not qualified and they do need orthodontic treatment. So don't do the minor malocclusion because it's not worth it. At the end, patient have to do this or wear this retainer, or they subject the patient for the long-term retainer, sometimes for lifetime. Are you going to wear the retainer for life? If not, then the teeth will move again. So even though you corrected this malocclusion, very minor rotation, they're not going to be stable. So at the end, patient have to go for either the fixed permanent retainer or the removable permanent retainer to maintain the result. So they'll settle one problem, but create another problem. Okay, so we finished the dental health component. Sorry, a bit long. From 5, 4, 3, 2, 1, according to severity. So you have to grade the patient according to the dental health component most of the time in the clinic or the government practice. But aesthetic component is an interesting one. So aesthetic component derived from the comparison of dental appearance of the standard photograph. So it's a direct clinical examination. So you see the patient mouth from the front, then you grade the patient according to the severity. So there are 10 standard photographs, which also graded from the score 1 to 10. So score 1 is the most aesthetic, score 10 is the least aesthetic. It means score 1 less severe, score 10 is the most severe. There are colors, then we have black and white. So color photograph usually for the clinical assessment, which you see the patient in the clinic. Then black and white usually you score the model alone on. So when you don't have the patient in your clinic and you use a study model, then you use a black and white photograph. When in the clinic, then you use a color photograph. So IOTN, this one is the aesthetic component. Right? There are two components. Then they have component, then we have this aesthetic component. So aesthetic component, they have these pictures. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and according to severity. So you can see number 1 and number 2, they're quite straight. They maybe have a little bit deep bite and a little bit overjet problem. When it comes to 10, then you have a crowding, and maybe overjet problem, overbite problem. So from 1 to 10, you grade the patient accordingly. Okay, so like I say, we have black and white, then colors. Black and white is more study model without the patient. Then we have colors photograph, which is with the patient in the clinic. So maybe we try one, then see what you think about this photograph or the mouth occlusion. So you look at this color photograph on the right side. Okay, just try to memorize this. I give you a pictures, then tell me what score you think this patient will get. Okay, ready? So 1 to 10, 1 to 10. Okay, what do you think about this patient? What score this patient will get? Someone say something. Or class rep say something. So from 1 to 10, what score you give this patient? Yeah, from 1 to 10, what score you give this patient?
4.
4? Okay, we have 4. Any other answer? What score you give these patients? According to this first impression or first glance, you think what score this patient will get? 1 to 10. So we have 4. What about others? No other answer? We have impacted canine, partially erupted, and left side maybe have crowding. Overbite is okay. We have crowding on the right side. So these patients, I think, yeah, personally, I would give maybe about 5 or so, 5 to 6. So you see, this one, we can have a different opinion about that. Some patients, or some people, other doctor, maybe will give you 6, 7. Some maybe will think about less severe, maybe give you 2 or 3. So we have to have an argument about this aesthetic component. How you assess the patient, like we say, the beauty light on the beholder. So this one, I think, very subjective and arguable. So whatever you say 4, I might not agree with that. I might argue with you based on this crowding impacted, that this patient might get 7 or 6. But you can argue based on the right side, this one, the crowding is not that too bad. I will give the patient 4. I wouldn't say you're right. I wouldn't say I'm wrong. It's not a personal judgment. Sometimes you ask the patient to grade themselves. So you give the patient these pictures, 1 to 10. You ask the patient, what do you think yourself? Which category you fall into? Of course, the patient will give you number 10. Because they want to qualify for the treatment. So this one, I think we seldom use it anymore because it creates a lot of arguments between the doctor and the patient. So for example, let's say I say, you only qualify if you're above 6 or above 5, then you qualify for the treatment. then patient may argue with you they fall into this category. Or the doctor, if they want to help the patient, they might grade the patient 6 to 10 rather than 1 to 4. So I don't use it anymore, but it's up to you. Let's say you want to use this, I think you just have to be careful. Be careful. There's some shortfall for this aesthetic component. So the score categorized according to the need of treatment. 1 to 2 is none, 3 to 4 is slight, then 5, 6, 7 considered moderate, then 8, 9, 10 is considered definite or severe treatment need. But this is average score can be taken from 2 components. Then the help component is widely used. So sometimes they take the help component, they take the aesthetic component, then maybe they divide into half average score. And the criticized for being subjective, particular for assessment. So, like I say, this the aesthetic component is very subjective, and we can argue the whole day about that. Then they usually didn't take into consideration for the class 3 malocclusion or anterior open bite, as a photograph only include the class 1 and class 2 cases. So you look at these pictures, you didn't see any class 3 or reverse overjet. You only have a class 1, maybe class 2, or maybe increased overjet, deep bite, but you didn't see any class 3 or open bite patients in this photograph. So this photograph doesn't include all the malocclusion. That's why I say there are bias. So this one I don't use it anymore. But again, if you want to use it, you have to use it with care. So I sometimes use this IOTN to grade the patients. So before we start, maybe this patient have the 5i, which is impactions, which cannot be visible in the mouth, total impaction, we give the 5i. Then when we finish, we give patient the score 1. So from 5 improve to 1. So aesthetic component, sometimes I give 7, it means they are quite severe. And when we finish, we give them 1. So that's how we see the improvement using the IOTN score. Okay, so we finish the IOTN score or IOTN index. Do you have any question for this IOTN? Which is quite important. So when you come to clinic later, you're going to do this clinical assessment or END, you have to write down the IOTN. Aesthetic component, no, but the dental health component, yes. You have to grade every single patient for braces or orthodontic assessment using this IOTN, dental health component. So you better make sure you understand fully for this dental health component. So before I start or go to other in-text, do you have any question to ask me regarding this dental health component?
Doctor?
Yep.
For 5i, just now you mentioned third molar included or not included?
Not included.
Okay, thank you,
Third
Doctor.
molar is not our business for braces. So
Okay.
we usually exclude the third molar, even though impacted, we are not counting. So let's say when it comes to missing teeth also, the 4H and the 5H, third molar usually excluded. Yeah, they consider something extra in the mouth, we don't take it into considerations.
Okay, thank you, Doctor.
Okay. Any other questions? Okay. If no questions, then I will proceed to the next in-text, which is a peer assessment rating, which is a PAS score. So this one usually we use it to grade the result. So let's say we have PAS score before treatment and after treatment. But this PAS score, because it's quite complicated, then usually we grade the patients according to the model. So it's to measure the success or failure of the treatment, then the score are recorded for the following parameter before and after treatment using the study models, not using the patients, because it's going to take maybe 10 minutes, 15 minutes just to get the score. So if you also ask the patient to open the mouth for the next 20 minutes, then maybe it's not fair, it's too tiring. Then this one is cumulative index. So every features of the malocclusion will get certain score. And that's why they invented these PAR rulers, which is easier to assess or to score the patients. So you look at these PAR rulers, they have the anterior and posterior, we have the cross bite. So this one is the anterior posterior interdigitations. So up to half unit or less than half unit, then they get a score. Transverse cross bite, then they have a score. Then vertical open bite, they have score. Center line discrepancy have score. Over bite, contact point or crowding. Then after that, they add in all these all these malocclusions features, the score. Then they give you a total score. So the features recorded are listed below. We will record the crowding by contact point displacement, Becker segment relationship in the anterior posterior, vertical transverse. It's in the 3D. We assess the occlusion in the 3D. Then we have overjet, overbite, and the midline also. So different between the pass score at the start and at the end of treatment is measured. So you get the model before you take impression, and after the treatment you get another impression. Then you get two model or two impressions. Then they pull out, they become model. Some they do a 3D scan, doesn't matter. You need to set the record before and set the record after. Then you measure from this. Then the percentage of changes in the pass score is derived. It's the reflection of the success of treatment. Then the mean reduction of greater than 70% indicate a high standard of treatment or successful treatment. Then the no appreciable improvement if change less than 30%. So let's say, for example, let's say the patient score 100. They have a score 100 before treatment. Then after the treatment, then the score maybe 20. So they're 80% improvement. That's considered the high standard treatment or successful treatment. So let's say you 100 score at the beginning, and at the end of treatment, if you score 80 or 70, which changes less than 30, then consider a poor treatment or failed treatment. So the field treatment pass score indicate the severity of the malocclusions, but they're using cumulative. Every features of the malocclusion will score something. Then after that, you add up all the score, then sum up, then come up with the figures. So obviously, it's difficult to achieve a significant reduction in pass score in cases with a low pre-treatment score. So let's say you have a little bit malocclusion here and there, then it is score high enough at the beginning, then you're not going to get a reduction at the end because it started with very low pass score. So that is not considered a great treatment. That's why for the governments or the UK governments or Malaysian governments, then we will try to allocate the resources to the more needed patients. So usually the pass score too low, then we wouldn't start the treatment because it's not worth it. So this diagram, it just summarizes what we said just now. Pre-treatment and post-treatment model are scored to give two pass score. So it's then possible to give the percentage of pass score reductions, or you plot the pre and post score on the nomogram. So let's say this one is a post-treatment total, then this one is a pre-treatment total. So like I said before, then you have to score the patients before treatment. So let's say I have a patient, then the score 55 at the beginning, 55 beginning. Then after treatment, then patient have the score 5. So you draw or plot the chart from the 5 and to the right side. Then 55 go up. Then the point they meet, then that's where they indicate the great improvement or improve or worse or no difference. So let's say I have a pass score 55 to start with, then have a pass score 5 to end with, then patient have a greatly improved treatment result. So let's say I have a 55 to start with, then later, after treatment, I have 45. Then this patient will fall into category worse or no difference. So let's say I have a 25 to start with, then patient later have a 10, then consider improve, but not great, improve. But let's say I have a patient have a 5 to start with, then later end up 5, no changes. Then patient is going to have worse or no different category. So you have a pass score low to start with, then it's very difficult to make the patient go to the group which is greatly improved. But if the patient have the high score or pass score to start with, then there's a very great chance they will fall into this greatly improved category. Yeah, I hope you get this. Very simple chart. So there's an example for my patients. Let's say I have a pass score to start with 28, then I finish, I have 2. then the percentage of changes is 93%. It's more than 70%, considered greatly improved. So of course, we can use this chart. 28 is somewhere around here. Then we have 2 is here. 2, 28. Then this patient will fall into the category greatly improved. Okay, so we finish with the past score. We're not going to go through all the details because it's not your job to score the patients. It's usually the orthodontist or the technician will do it. So ICON is the index of complexity outcome you need. Then features the IOTN and the past score. So they combine all these past score and the IOTN together. Then it becomes an IOTN, index of complexity outcome and need. So why we have this index of complexity? So it's just to identify who should treat the patients, whether the general practitioners or the specialists or the consultant should treat the patients. So to allow more meaningful assessment of the treatment outcome, and then to identify which cases will take longer to treat. So of course, the more difficult case will take longer time to treat compared to the easier case. Then to be able to inform the patient of likely success. So if they're very difficult case, very complex, then maybe you tell the patient you're not going to get the great result at the end, but you're going to get the improved result. So this one will give you the estimations, how difficult and how long the treatment will need. So how they come up with this index of complexity. So there's a 97 order on this, then they come together, then they grade sample 240 initial and 98 treated study model. So they have 240 before start and 98 after treatment models. And based on this, all this model, then I come out with a summary, which is the 5 highly predictive occlusal traits were identified, which is using the IOTN aesthetic component, crossbite, upper arch crowding and spacing, then buccal segment, anterior and posterior relationship, then anterior vertical relationship, open bite, deep bite, and all that. Then they come up with a score, but each score will carry a different weighting. So this aesthetic component, then you have to times 7. So they give you a weighting of a 7. Then upper arch crowding or spacing, they have to times 5. They give you 5. Then cross bite times 5, oval bite, open bite times 4, buccal segment relationship times 3. So don't ask me why they're times 7, times 5, times 4. This is based on the 97 orthodontists, their opinions. So I might not agree with that, but that's how they come up with the score. So they add the weighted score to come up with the final figures. So after you times 7, then they come up with figures, then sum up all these figures, then they give a score to the patient's complexity. So 20 percentile range are used to determine 5 grades of complexity improvement. So they use 20, 40, 60, 70, 80, and 100. Total sum give a pre-treatment score which is scaled to reflect the need and likely complexity of treatment required. So score higher than 43 is the demonstrable need for treatment. So this one very simple. Then they usually have this easy, mild, moderate, difficult, and very difficult based on the sum of the amount of score. So pre-treatment considered cutoff value. Okay, so same thing. So they have to classify the patients complexity based on the easy, mild, moderate, and difficult, and very difficult. Then improvement grade is a pre-treatment score, then minus 4 times post-treatment score. So don't ask me why they come up with this formula. Again, it's based on this 97 orthodontist opinion. So what's the limitation? So you go back to the slide, you see they give aesthetic component, the weighting is about 7, which means this aesthetic component is so important, times 7 times. So they give her large weighting to this aesthetic component, which we discussed before. This aesthetic component is very subjective and debatable. Some will give a bit more, some will give a bit less. But if times 7, then it's going to give you a large score difference. So hence, they are not getting the widespread acceptability. So not many people using it anymore because I just don't think they're accurate enough if you're based on this aesthetic component so much. Of course, we have this pre-treatment, then we have then minus this post-treatment times 4, then we have less than -1, then less than 25 to -1, this then the score, then they give you all the improve or minimally improve or no improve or worse or greatly improve. Same with the pass score. Okay, so now finally we come to summer occlusal intact. And then this one again developed by this called Summer in USA in 1960, which is about 60 years ago, then used for epidemiology or research purposes. So because of lack of agreements amongst the investigator concerned with the measuring occlusion for epidemiology purpose, then an attempt has been made to develop intact occlusion, then which would serve this purpose. This intact will call the occlusal purpose, occlusal intact. So this score the following parameters: the molar relationship, class 1, class 2, class 3, overbite, then deep, open bite, whatever, then overjet, increase or reduce, then posterior cross bite, posterior open bite, 2 displacement, which is crowding, then midline relationship, upper midline, lower midline, they are coincide or they have discrepancy, maxillary midline transdermal, spacing, then absent or upper incisor, which is hypodontia. So what's the advantages of these occlusal intakes? They are good reproducibility. It means every time people will score, they get the same result. They're employed to determine the success of treatment with acceptable result. Allowance is made to different phases of development. So they will score the patient according to different stages of phase, deciduous, mixed, or permanent dentitions. So they are more flexible because they're based on this parameter or the occlusal trait. So what's the conclusions after we listen so many syntaxes or indices? Then we have to come up with a conclusion. So index of choice or any research depends upon its purpose. So let's say you want to measure only the severity of the malocclusion, then maybe you can use IOTN, but you want to measure the result, whether they're successful, greatly improved, or they have failed. Then maybe use the pass score. And for maybe you want to measure the malocclusion or the occlusion features of this population, then maybe use summer occlusal index. Then you want to measure the complexity of the treatment, then maybe use an icon. So it depends what purpose you want to measure. So it's important to define the type of malocclusion can be measured clearly for the good validity of research. The adequate training and calibration use of chosen indices is necessary for the accurate and consistent diagnosis. So whatever I taught you just now, the IOTN, then the health component, I know there are big confusions, but doesn't matter. When you come to the clinic, then we will do some training, or maybe we'll do some calibrations, then you will know it a bit better. Every time you score the patient, there's always a room for improvement. So a good method of recording and measuring malocclusion is important for documentation and prevalence of severity population group. Yeah. So you have to write down the LTN and the health component usually for all patients. And this kind of data is not only important for epidemiologists, but also for those who plan the provisions of orthodontic treatment in the community or for the training of the orthodontic specialists. So let's say I know that Selangor, there are so many patients with the class 2 division 1, then maybe I train more orthodontists or dentists that do the functional appliance, or maybe we'll allocate more money to Selangor rather than other states. So the method of universally accepted and applied data collected from different population groups can be compared. So I can compare Malaysia and UK, or we can compare Malaysia, Singapore using the same data, the same method or index. The data collected we can compare. Okay, so this one is not related to our index. So we just say that profit is so-called the modern fathers of orthodontics. So a very popular orthodontist in USA, but I think he passed away last couple of years. Occlusal problem can be identified solely on physical terms. They say the psychosocial consequences due to unacceptable dental aesthetic may be more serious, even more serious than the biological problem. So you say the malocclusion can bring a lot of social impact or psychology problems to patients. It's more than you can imagine. So never underestimate. Even the malocclusion might just some displacement to you, but the psychological impact to the patient is more than you can imagine. So what I like about orthodontics is when you treat the patients, after 2 years or 3 years of treatment, they become friends with the patients. Then at the end, the patients will be very happy, and your service is great, appreciable. So that's what I like about orthodontic. So that's my reference. Do you have any question to ask me before we end these lectures? So I hope later we're going to have this tutorial, then we can go through some cases, then we're going to score them together. Then you can learn how we do the dental health component. Yep. Do you have any question to ask me?
Doctor, for
Go ahead.
clinic, which indices we are going to use other than IOTN, which you have taught just now?
Yeah. For MASA, for your clinics, only IOTN and the health component. Pascal, Icon, occlusal index, you're not going to use it. But I focus more on this IOTN, only the health component. Even the aesthetic component, we're not going to use it in muscle. But if you see somewhere else that has this, at least you know what's that.
Thank you, Doctor.
Okay. Any other questions? No other questions? If no other question, I think I will end this lectures. I know this lecture is a bit boring, but it's very important for the dental health component. So you can forget about other indexes, other indices, but you have to focus on this dental health component for IOTN. If you're going to stay in Malaysia or you're going to UK, this IOTN is super important. But when it comes to private practice, to be honest, no one care about that, because at the end, it's all about the revenues or the money you're going to generate for the clinic. So whether the patient have the low needs, you still have to treat the patients because we are more profit oriented. So yeah, I'm just trying to be honest with you. But this index is very important when for the government to allocate the resources, especially the monies and specialist allocations. Yeah, with that, I think I end these lectures. So I'll see you soon. Yeah.
Thank you, Doctor.
Thank you, Doctor.
Bye.
Thank you, Doctor.
Thank you, Doctor.